Hello, this is Dr. Donald Pelto, and welcome to Healthy Living. I have my guest here, Dr. Jason Mehling. He is an interventional radiologist over at St. Vincent Hospital in Worcester, Massachusetts. Jason, thanks for joining the show.
Well, thank you very much for having me. It's great to see you again. We'll try not to let the Minnesota accents come out too much.
Yeah, that's the joke between us. We're both from Minnesota. That's our homeland, and we always reminisce about that when we're together. So, Jason, we're going to talk a little bit about kind of what you do. The reason we met is because your team is the one that reads our vascular studies that we do here in our office. And that might be a small portion of what you do as an interventional radiologist. But I'd like to ask kind of how did you get interested in being an interventional radiologist? Is that someone that just reads x-rays, or does it do a little bit more?
So I got interested in medical school, and I was looking for a field where I could interact with patients, but also read x-rays, and interventional radiology is basically that field. It's a subspecialty of radiology where we do image-guided procedures through the skin. It's minimally invasive. Usually it's done on an outpatient basis, requires a little bit of local anesthetic and sedation, and most of the time the patient will go home the same day without any stitches. So it's kind of operating inside the body without being a surgeon, using image guidance.
And as an interventional radiologist, are you consulted by others to do your work? Do you have your own patients? Do you kind of work in teams with other physicians? How does that work?
Typically, we're working in consultation with other physicians. When you talk about a radiologist, they usually call a radiologist a physician's physician, but the interventional radiologists are the radiologists that have a more clinical background. So sometimes we will see a patient in clinic who's referred to us by another specialist or a primary care physician in consultation for treatment. And then we'll bring that patient to treatment and recovery, and then we will follow them after the procedure, just like other surgical specialties, although we're not surgeons per se.
It's interesting. I know you say you're not a surgeon, but you do. Do we call them surgical procedures, or is that what we call the interventional procedures?
Well, there's kind of, when you talk about just angiography as an interventional procedure, there's a whole group of different doctors that do angiography.
Let's simple that. What is angiography for those that are watching?
So imaging the blood vessels and performing image-guided procedures from inside the blood vessels are some of the image-guided procedures that we do as interventional radiologists.
Perfect.
And there's other subspecialties that train to do those kind of procedures, but they train in a different format. They may be a vascular surgeon who's trained in surgery and then vascular surgery, then endovascular surgery, or it may be a cardiologist who's traditionally trained as an internal medicine doctor, and then they learn how to do endovascular or image-guided procedures on the heart.
And so we're going to talk specifically, let's talk about something that's close to my heart because of my patients, those that have claudication symptoms. And for those, maybe you can explain a little bit what claudication is to those that they might not heard that word, and how you guys can help that.
Basically, the medical definition in a layman's explanation, which my grandma always wanted, was pain with walking that gets better with rest. Pain with walking that gets better with rest has a whole list of things that cause it, but it's usually a vascular cause from a blockage or narrowing somewhere in the artery. That blockage can usually be localized by doing other imaging, like non-invasive vascular lab testing.
And so these non-invasive, these are the ones that we send over, or are they more advanced? I think an ABI is one type, and then there's a MRA and things like that. So maybe go over what those are, and you guys read those, I guess, as well?
Yes, we do. So the screening examinations that you guys do in your office identify people with vascular disease, and then we can do more high-tech imaging to figure out where exactly the blockage is and how severe the blockage is, and decide how we want to treat it. Actually, the first treatment, there's kind of two first treatments. One is controlling any factors that lead to vascular disease. That's controlling high blood pressure, diabetes, getting the patient to stop smoking, controlling the patient cholesterol levels. And that's usually done in conjunction with the primary care physician. But if the patient is symptomatic, then they may want to start on an exercise program, which will help produce collateral blood flow and decrease their symptoms. If they fail an exercise program, they're unwilling to do the program, or if their symptoms don't get better with exercise programs alone, then we can perform an angiogram, find the area of narrowing, and then we can use either a balloon or stent to open that blood vessel back up to the normal size of the blood vessel. And treatment really depends on the location of the blockage and what the blockage looks like as to which, whether we balloon it or whether we stent it.
Okay, so for these patients that get sent to you and they have these symptoms of cramping when they're walking, just as a generic number, those that, let's say, okay, I'm going to change my diet, I'm going to start exercising, is that pretty effective at kind of reducing some of the pain, or does everyone need to end up having these procedures? What in your experience?
No, absolutely. The first thing they should do is an exercise program, and that can increase their or decrease their symptoms significantly. The problem is, just like any physical therapy, and I've been through it with my knee, it's hard for patients to be compliant with a long-term exercise program. So they'll want to try to come to a fix that's quicker, easier to get to, or they'll fail the exercise program, or they won't get the symptom relief that they want. So usually by that time they're already at the severe vascular disease stage.
Okay.
So claudication rarely goes on to amputation. So those patients are usually symptomatic, but they're never going to lose a limb from this. So what they want to do is get a treatment that can get them back to their normal lifestyle.
And I think you say something good, Jason, about lifestyle. If you're dealing with claudication daily, you're not going to have very good quality of life. You're not going to want to walk or do activities like that. So they come to you, they've tried it, didn't work. And now what can a patient expect when they have an interventional radiology procedure? Kind of walk us through what that's like.
Okay, so most of our patients have an outpatient, minimally invasive procedure with conscious sedation. So I'll go through each kind of those steps. An outpatient procedure, you basically come to the hospital the morning of the procedure. You're seen by the physician performing the procedure. We'll talk to you about the risks, the benefits, how long the procedure is going to take, what position you're going to be in, what you can expect for pain during the procedure, and what the recovery is. If we're going to give you medications or sedation during the procedure, a nurse will start an IV, and then we'll bring you into the procedure room. We do a prep and a drape, and then usually we use a local anesthetic, lidocaine or novocaine, just like going to the dentist. I always hate to use the dentist analogy because no one likes going to the dentist, but everybody kind of knows what lidocaine or novocaine is from being at the dentist. So we'll numb up, and then we'll also administer what's called moderate conscious sedation. And what that is that's a combination of a pain medication and a sedative via IV or in your IV. And when you give those two medications together, you get kind of what's called a twilight sleep. It's not like general anesthesia where I want to knock you out. I don't care if you're awake or if you're asleep during the procedure. I want you comfortable without anxiety or pain. So if you're comfortable, you don't have any anxiety, you don't have any pain, you're breathing on your own, that's where I want you for the procedure, because most of these procedures are not long or not painful procedures. The nice thing about moderate conscious sedation is it gives you a little bit of retrograde amnesia. The nice thing about moderate conscious sedation is it gives you a little bit of retrograde amnesia. That's my joke. That means that you don't remember what was just said. So the nice thing, well, I won't go there a third time, but the retrograde amnesia just gives you a little bit of, I don't remember how long the case really was, but I feel like it was maybe 10 or 15 minutes when it was an hour. Or sometimes we'll have patients who are kind of complaining a little bit about being uncomfortable during the procedure, and then halfway through the procedure, they stop complaining about it. And at the end of the procedure, they go, oh, I don't even remember anything happening.
Yeah.
And so my goal, I always tell, is safe and comfortable. People say, oh, I want you to knock me out. But to knock you out, I have to have general anesthesia and I have to basically put a breathing tube in and breathe for you. If you're on the table, you're comfortable and you're breathing on your own and I'm doing the procedure, that's exactly where I want you. And then afterwards, we can send you to the recovery area and in an hour or two, you're ready to walk out the door.
That's great. And now with let's say claudication would be some type of a problem with the circulation. Do you remove the problem or do you just stretch out the vessel? There's a Roto-Rooter type of a device and there's a balloon that opens it. Which one do you use mostly?
Mostly we use a balloon, and what that'll do is that'll push the plaque into the wall of the blood vessel. Similar to opening up a pipe, except the clog in the pipe gets pushed sideways, not removed by a plumber. Mm-hmm. The other thing that we may use is called a stent, and a stent is either a covered or uncovered piece of metal tubing. Looks just kind of like a tube, and we deploy that stent to stretch out the blood vessel. Now, there's places where the stents work really good, and then there's places where you don't want to put a stent. You don't want to put a stent across a joint that moves because that stent will fracture. Okay. And then as the blood vessels get smaller, you can kind of go by fluid dynamics, which we won't go into, but basically a stent doesn't work as good in a smaller blood vessel. It's much more likely to clog because of the dynamics of flow through a smaller and smaller tube. Yeah. So in really small blood vessels, then we usually just typically use a balloon. A few years ago, we were using drug-eluting balloons, and then there was a big study that came out that showed that drug-eluting balloons actually had a higher complication of increased death rate in patients. So we stopped using the drug-eluting balloons, and now they're studying them much, much closer as to whether or not that data was correct. So.
There's something that you guys do that's very interesting, I find, is you can actually go, instead of from the big part of the vessel to the smaller, sometimes you can go from the toe upward too, like a retro, they call it, going back kind of backwards for maybe wounds or opening up smaller foot arteries. That's kind of what I do, and probably other parts of the body.
Yeah, if we have a blood vessel that we can't get down from the top, we sometimes will go the other direction, what's called a retrograde approach, or from the backside, we'll go against the blood vessel flow and see if we can get a wire up and through the blockage from below, not from above. And if we can get up from below, we can snare and kind of make a connection through and through to try to reopen a blood vessel that may have been closed for a really long time. That's really critical in a patient with like a non-healing toe wound, or a patient with a threatened limb where they may be looking at an amputation if they can't heal the wound. Yeah. And I think that some of those patients are patients that you see more commonly than the patient who's a claudicant, who's probably not going to have a problem with wound healing.
Yeah, yeah. That's something whenever there's a wound, we try to at least get some type of a circulatory, because that could be one of the causes to the slow healing.
Right, right.
Now you do something that I don't do anything with. You also kind of work in conjunction with some cancer patients as well, oncology treatment. That's kind of interesting. So tell us a little bit more about that.
Yeah, as a lot more vascular surgeons became trained in endovascular procedures, we're seeing a little bit of a downward turn in our vascular volumes, but what we've seen is a real increase in the field called interventional oncology. And what that is it's a subset of procedures that we perform basically to diagnose and treat cancer. There's two kind of major types of procedure. One is called an ablation, and the other is called an embolization. And I can kind of talk about them separately because we do them in much different ways. What an ablation is that we'll find the tumor. Sometimes we'll biopsy it at the same site, but basically we'll put a needle into the tumor, and then we'll either cook it or we'll freeze it inside your own body. And then your body will get rid of those cells because they're no longer living cancer cells. We can do that through a very small incision because the needles are a little bit bigger than the needle that you use to start an IV. You just need to use image guidance and make sure that that needle is in the appropriate position and it's not going to harm other structures in the area. We can do that in any part of the body, literally with ice or with microwave.
Wow. So just so I understand, what we were talking about before, you followed a blood vessel.
Yep.
And what we're talking about now, it's kind of like putting a needle in a balloon. You just kind of, you go, you don't have to have a vessel to follow. You can go right to the anatomy.
So let's say that you had a tumor in your kidney.
Mm-hmm.
We would bring you in. We would have you in our CAT scanner. We would put a little needle next to the tumor, and we would take some samples of the tumor. And then we would put a needle directly into the tumor, and we would turn on a little device that creates a microwave frequency right at the tip of the needle, which is in the tumor. And then based on animal studies and tissue studies, we would say that we want to do a 4 by 5 centimeter burn for a 3 centimeter tumor. And basically what we're doing is we're killing the tumor, and we're killing a small rim of tissue around that tumor, which is normal tissue, but we'll prevent the spread of that tumor or the recurrence of that tumor. We then take that probe out, and we never remove the tumor. Your body will remove the dead cells, and then we just follow that site with imaging, and you usually go home the same day with a Band-Aid on your back.
Wow. And so just so I understand, you would probably get an imaging before this, either a CT or an MRI, to find out the exact size. You probably can do it. It's better for isolated or single lesions than it is for multiple lesions.
Yeah, there's some data out there based on number of lesions, size of lesions, location of lesions, and all that goes into our training and decision pathway. Oftentimes you'll find that there's no right answer. There's multiple choices of treatments. And so we'll sit down and we'll confer with our oncology colleagues and our radiation therapy colleagues and our other interventional colleagues and say, how would you treat this tumor? What's the best treatment for this patient? Some of the other things to consider is how old is the patient? What other comorbidities does the patient have? Are they going to tolerate a surgical procedure, an interventional radiology procedure? Are they going to tolerate chemotherapy, or will they even tolerate a biopsy? So those are sort of the decision pathways that we make in conjunction with our oncology and radiation therapy colleagues and surgery colleagues to decide how to treat a patient.
Wow.
So every week we have a cancer conference on Friday at noon at the hospital and discuss multiple patients and treatment options. And we bring our hammers and nails, as they're called, to the table, and the surgeons bring theirs and the oncologists bring theirs, and we decide what is the best treatment specified to each patient.
Wow, that's great. That's great for the hospital to have that team approach.
Yeah.
So one aspect you said was were the ablation of it. What was the other aspect that you guys do?
The other aspect is called embolization, and it's very similar to what we were talking about earlier, working inside the blood vessel. So for another example, let's say you have a tumor in your liver and it's confined to your liver, and we know it's a liver cancer. We would then do an angiogram, very similar to like we're treating a blood vessel for claudication, but we would localize the blood vessels that are feeding just that tumor. So the tumor's out here, and there's different blood vessels that feed that tumor. And then when we figure out which blood vessels are only feeding the tumor, we can inject beads that are coated in chemotherapy or beads that are coated in a yttrium-90 radiation emitter. And so the patient will get a really high dose of chemotherapy in the tumor or really high dose of radiation in the tumor without getting a lot of the side effects that you have with systemic therapies.
Wow. That's interesting. And it's probably evolving because cancer treatment is just evolving daily, basically. So
it's absolutely evolved from the time I finished my training in 2006 through today. And I anticipate in the next 15 years it's going to change, not 180 degrees, but it's going to change majorly over the next 15 years again as new technologies evolve. Some of these procedures I was just starting to do, they were just starting to become very popular 15 years ago, and now we're doing them, almost on a weekly basis.
Wow, that's interesting. Let's talk a little bit more about some of the other procedures that you can help with. I know you talked about like the biopsy, the joints, some looks. Kind of explain what are some of these other procedures?
So we do a lot of image-guided procedures on inpatients and outpatients on a daily basis. Thyroid fine needle aspirations for thyroid nodules, joint injections, something that's called a hysterosalpingogram, which is to evaluate a woman's fertility. And basically, the image-guided procedures are more accurate, they're safer, they have less pain, and so the patients have a high deal of satisfaction because we're putting the needle exactly where it needs to go. We're not blindly putting the needle into the joint. We put the needle into the joint and we check with X-ray dye before we inject the steroid, or we're proving that we're in the thyroid nodule versus just feeling the nodule and saying, I think it's there, and then putting the needle in through the skin. We watch the needle the whole time, proving that we're in the thyroid nodule. So the image-guided procedures are very elegant, oftentimes with very little pain and a very high level of satisfaction. So, you know, I don't want to say we're the jet fighter pilots, but somebody else told me once, you guys are the jet fighter pilots. And no, we're not nearly that cool. But it's just that kind of using high technology to do minimally invasive procedures really turned me on to the field of interventional radiology, because I started medical school thinking I just wanted to be a family practice doctor working out in the country. And this sort of hooked me as you know, you got to be a little bit geeky, and you got to really like understanding the image. And you also have to want to be able to treat patients. And, you know, so you have to have the empathy of a physician who wants to take good care of their patients.
Yeah, wow, that's great. And now as we finish up, just the last question, in terms of everything that we're dealing with COVID right now, has that changed something with your work? Any new types of work, less work, changing?
Yeah, so the first thing we did is we looked at all non-urgent procedures and we put them on hold. The non-urgent procedures are things like the joint injections, the thyroid nodule FNAs, which can be followed with ultrasound. So basically, we almost immediately cut our volumes in half. The hospital volumes have dropped significantly. The ER visits have dropped significantly. Unfortunately, people are not seeking medical care when they really need to for fear of, I don't want to go into the hospital and be exposed to COVID. If they have an urgent procedure, they should really go to the ER and be seen. One of the other things that the hospital did in conjunction with UMass is they set up a homeless shelter. So one of the problems that we have in Worcester is we have a homeless population that if they get sick, they have nowhere to go. So these patients are homeless people who have COVID, and they need a place to quarantine. So they set up a homeless shelter in conjunction with UMass, and they also set up a field hospital at the DCU Center in conjunction with the University of Massachusetts Hospital. So our administrative teams are meeting daily to make sure that we have the PPE that we need, which is the personal protective equipment, that we have enough ventilators, that we have enough staff. And unfortunately, we've been having to furlough nurses and other staff because the hospital volumes are down because we're only dealing with the very, very sickest patients and patients with COVID.
Yeah.
So as those restrictions will start to ease, hopefully people will start to take care of other problems that, you know, like heart disease, vascular disease, that will become, you know, urgent over the next month. So.
Yeah. Great.
Yeah.
Well, thank you, Jason. I just want to conclude, as we say, this is Dr. Jason Mehling. He's a interventional radiologist from St. Vincent Hospital. If they want to learn more about interventional radiation therapy, things like that, do you guys have a website or something that they can go to?
Well, they can go to the St. Vincent's Radiologic Associates group to find out about my partners. Our society website is SIR, or the Society of Interventional Radiology, and they have a lot of good information on what interventional radiology is, who we are, and the procedures that we do.
Great. Well, thank you so much for being on the show, Jason.
Great. Thank you so much for having me.
Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.